Welcome to This Explainer. Today, we're diving straight into a massive financial disparity in healthcare economics. It's something that affects literally millions of people, yet it operates almost entirely behind the scenes. Based on some fascinating recent data from the FEM Technology Intelligence Suite, we're unpacking what they call the invisible tax. Essentially, this is the hidden premium women pay for a healthcare system and an insurance apparatus that, frankly, just wasn't built with their biology in mind. So let's get right into it by confronting the core premise that actuaries use to figure out your healthcare premiums. Have you ever noticed that health and life insurance premiums for women are frequently higher than those for their male colleagues? The standard line from the insurance industry is super simple. Women just cost more to insure over their lifetimes. They generate more visits, more claims. But is that actually true? Or is it a symptom of a deeply flawed system? To see how this plays out on a global scale, let's take a quick look at Switzerland. The data there shows that women pay roughly 12% more for supplementary health insurance than men. And what's really wild is that this disparity spikes to a massive 37% difference by the time a woman hits age 31. 37%. That is an incredibly heavy financial burden. And if you want to see the sheer scale of the issue here in the U.S., just look at the out-of-pocket void. Employed women in the United States are saddled with $15 billion more in annual out-of-pocket healthcare costs compared to their male counterparts. Yeah, you heard that right. $15 billion every single year, strictly out of pocket. It's absolutely staggering. Here's how we're going to systematically decode this invisible tax today. We're looking at 1. The actuary's mystery. 2. The diagnostic friction tax. 3. Paying for wrong care. 4. The menopause black hole. 5. The illusion of fair pricing. And 6. Reclaiming your consumer leverage.
Let's start with Section 1, the actuary's mystery, risk and historic claims.
So the whole architecture of global insurance relies on the actuary, right? This is the mathematician predicting your lifetime cost to the system based on historical claims data. Because women historically generate more healthcare visits, higher pharma costs, and more late-stage surgical claims, the system just concludes, well, women are simply expensive. Therefore, premiums go up. But the insurance industry is entirely missing the underlying cause here. They're assuming women are biologically frailer or just hyperutilizers of care, when in reality, it's a mathematical sleight of hand masking a deeply inefficient clinical pathway. Which brings us to Section 2, the diagnostic friction tax, systemic delays in care. Now, it's pretty wild to see how clinical data actually gets lost in the system. The healthcare apparatus is highly optimized for acute, event-driven emergencies, think like a sports injury, but it's notoriously bad at managing chronic, multisystemic conditions that disproportionately affect women. Take endometriosis, for example. There are literally 178 specific diagnostic ICD-10 codes for it. But instead of using those precise codes, the billing often just defaults to generic misrouted codes for things like IBS or unspecified pelvic pain. The diagnostic pathway specificity is functionally just erased from the system's memory. So what happens to the patient in all this? Well, because the system doesn't immediately recognize her biology, a patient seeking an accurate endometriosis diagnosis will bounce from a general practitioner to a gastroenterologist, maybe to a psychiatrist, often getting prescribed totally irrelevant medications. I mean, look at this staggering diagnostic journey, one that on average takes 6 to 9 years. To the actuary looking at a spreadsheet, she looks like the super expensive overutilizer who booked 5 different specialists and generated thousands in scans. But she didn't want 5 doctors. She just wanted one accurate diagnosis. And you are paying the premium for the system's failure to provide it. Moving right along to Section 3. Paying for wrong care, the out-of-pocket void. Now, cardiovascular disease is the #1 killer of women. Yet, consider how we actually test for a heart attack. Standard emergency room blood tests, specifically the cardiac troponin test, use a diagnostic threshold that's formulated largely on male data. The catch? Women naturally harbor a lower baseline level of troponin. So this means a woman actively having a heart attack frequently tests below the threshold on this male-calibrated test. And what happens? She gets sent home with antacids instead of receiving life-saving cardiac care. It's unbelievable. So here's the crucial point. Because that early intervention was missed, the damage progresses. Eventually, the insurance company has to shell out for an enormously expensive late-stage cardiac surgery, sometimes upwards of $150,000. And this could have been entirely prevented with early detection and $50 a month preventative medications. To recoup that 150 grand, insurers just raise premiums for all women. You are literally paying higher premiums to subsidize a system that outright refuses to buy and use sex-calibrated tests. That leads us to Section 4, the menopause black hole, ignoring prevention. When a woman enters perimenopause, estrogen, which is a really critical metabolic governor, plummets. But do standard insurance plans cover comprehensive, proactive hormone replacement therapy, which might only run about $200 a year? Rarely. Instead, they fragment your care into a highly expensive cascade. It's like a domino effect. They'll gladly pay for SSRIs for mood swings, then sleeping pills for insomnia, then statins for cholesterol spikes. Decades later, they pay an absolute fortune for osteoporosis-related hip fractures and advanced cardiac care. Basically, you're forced to pay for symptoms over decades rather than treating the underlying hormonal decline, and those massive costs get passed right back to you via your premiums. Next up, Section 5, the illusion of fair pricing, omitted variable bias. How does an industry based on complex risk models get away with such a glaring mathematical error? Well, it comes down to a statistical failure known as omitted variable bias. The actuaries aren't actually pricing your biological risk. The model fails to include the correct variables, like the diagnostic delays we just talked about, or those male-calibrated testing thresholds. Instead, the industry uses gender as a broad, lazy proxy. They're basically treating being female as the root cause of the higher costs, completely covering up the fact that the clinical pathway itself is defective and delaying your care. This really brings to light the uniquely bad consumer economics of healthcare. Think about it. If you buy a defective premium smartphone, the manufacturer absorbs the cost of the recall, right? But in healthcare, when the clinical pathway is fundamentally defective for half the population, you, the consumer, are forced to absorb the cost of that defect through higher monthly premiums. You are literally funding the medical establishment's systemic blind spots directly with your own wallet. Okay, time for Section 6, reclaiming your consumer leverage, correcting the market. The good news, you hold the ultimate power to correct this market. Look at the massive disparity in spending power. Women drive roughly 80% of all household healthcare spending decisions. Collectively, women represent the single largest economic bloc in the insurance market. That is absolute financial leverage. Insurance companies might not possess clinical power, but they possess absolute financial power. And believe me, they do not want to lose their most lucrative demographic bloc. And this change can actually happen at the highest levels. If consumers start demanding sex-stratified coverage, major life and health reinsurers have the power to enact what are called treaty conditions. Basically, this means they can offer favorable, discounted rates to primary insurers who actually implement these correct sex-calibrated care pathways. When the primary insurer gets a discount for doing the right thing, your monthly premium ultimately goes down. It's a win-win. So let's dive into exactly what you can do right now to demand transparency and force this market pivot. First, request a sex disaggregated claims summary from your insurer. Second, ask them point blank if menopause-related treatments are covered as a medical necessity, not just as something elective. Third, start tracking your own diagnostic journey, the number of providers you've seen, the time it took, and your out-of-pocket costs. And finally, advocate for your employer to adopt sex-stratified benefit designs in the workplace. I want to leave you with this vital question. Is your insurance plan actually built for your biology? By understanding the mechanics of the invisible tax, you completely shift the narrative. You cease being a high-risk anomaly and realize you are a misserved consumer. Your biology is not a liability, and it is time you stop paying them to treat it like one. Thanks so much for joining me for this explainer, and I really encourage you to take a hard look at your own coverage today. Catch you next time.